Come on, please start.
Come on, please start.
Kindly unmute yourself. Yeah, thank you.
Good evening, everyone. I'm Dr. Shikha, pediatric rheumatologist from Mumbai and Secretary Mumbai IMP, and it's my pleasure to invite you all to this virtual meeting on pediatric rheumatology today. So before going ahead with the session and introducing our esteemed speaker, I would like to invite our own Maharashtra State IAP President, Dr. Ram Gopal Shijara sir, to kindly address us.
Recording in progress.
Am I audible?
Yes, sir.
Can you hear me? Yeah.
Yes, sir. Yes, sir.
Good evening, friends. Welcome to another episode of Pictorial Pediatrics. As the name suggests, we are going to learn, but in a different manner and different mode. It would be learning by the pictures. So the topic decided is a rheumatology. And as you know, आप लोगों ने मूवी में देखा रहेगा कि most of the movies अमिताभ का नाम रहता है विजय. So we have a Amitabh of rheumatology, that is Vijay Vishwanathan. He is the chairperson of the Rheumatology Association and my close friend. So welcome, Vijay. And today we have a moderator who is also a rheumatologist. So welcome, Dr. Shikha Agrawal. I will not take much time. Already we are late. So over to Shikha, and Shikha, you can start.
Yeah, so I would also like to invite our hardworking secretary of MahaIP, Dr. Amol Pawar sir, to kindly give us a few words.
Thank you, Dr. Shikha ma'am. First of all, thank you for accepting to be as a moderator for today's session with yet another rheumatologist, Dr. Vijay Vishwanathan sir. Vijay sir is a regular faculty at state and national conferences, and there is a lot to learn from him. He has very various ideas to put forth all the points or what the catchy points in rheumatology cases to all the delegates wherever he goes. He's just popular and he's very good friend of us. So welcome all the delegates, PG students, all the office bearers of Maharashtra IP branches, EB members, and the members from other states also to this wonderful webinar of Pictorial Pediatrics. As already Ram Gopal sir has told that with the help of pictures, we are getting the knowledge about the case, means case dissection, or getting the with the pictures we are getting inputs to how to diagnose the case and how to go ahead about this. So I welcome both again Dr. Vijay sir and Dr. Shikha ma'am, and will ask Dr. Shikha ma'am to proceed further. Thank you.
Thank you so much, sir. So now I would introduce the speaker of the day who needs no introduction, Dr. Vijay Vishwanathan. He's the doyen in pediatric rheumatology in India, in Maharashtra, in Thane. And he's the current chairperson of Pediatric Rheumatology Society of India. He has multiple accolades to his name, multiple publications, posters, textbook, chapters in textbook. But we all have heard his presentations and we know how his presentations are filled with fun and pun both. So he makes complex topics of pediatric rheumatology engaging and even masterable. So before taking much time, I'll give the stage, the virtual stage to sir. Sir, you can kindly share your slides and start.
Sir, kindly unmute. Perfect.
One second. I'm audible, right?
Yes, sir.
Now you're audible, sir, but you need to go on full screen.
Yeah. My keyboard has got stuck. It says it's
Yes,
9
it is.
o'clock. Yep. Now it's audible and
Yes,
visible,
audible.
correct?
Yes, sir.
So thank you, Ram Gopal, Amol, MahaIP, for Dr. Bhavesh in particular for asking me to do this for the pediatricians of Maharashtra and the country. Thank you, Shika, for the kind introduction, and I should congratulate Ram Gopal for convincing me to be staying awake at 9 o'clock Indian Standard Time in the evening. I hope I am able to do justice and keep you all awake till at least 10:30 for tonight. So the topic for today is learning through pictures in rheumatology. I think if there is one specialty which can be learned through pictures without much of complicated literature, etc., it's rheumatology. And I often start with these two slides, and you can the audience is free to put their comments in the chat box, the questions that I keep asking, and we could probably take them up all at the very end of the session, right? So these are two kids who actually walked in to my OPD with a suspected diagnosis of JIA, and the kid on the right actually had a t-shirt which was saying JRA. And as pediatricians, we've always been taught disto tasa nasto. So you always start looking and seeing. But what's the difference between seeing and looking? All of us see our patients. But at the end of this talk, the purpose is you better start looking for clues. And for the non-Maharashtra crowd, there's a saying which says disto tasa nasto. Manun jug fasto. The idea is we should not be fussoing with this comment. So my twist on this is disto tasa nasto, त्यातच निदान पण असतो. Translated to English, जो दिखता है वही दिखाता भी है और वो सिखाता भी है. So I want all of you to just start listening to me, not just hearing, and start looking at the pictures for the clues I'm going to share with you. This is one branch where all of us have, or none of us have ever studied during our undergraduate days or our PG days. So to the untrained mind, all the joints will look the same. And the question is, which of them is what? So hopefully by the end of this lecture, we should be able to notice small and subtle differences and pick up which one is what. So let's get started with the first group of disorders, right? So the commonest patient that you will encounter in your OPD or day-to-day OPD basis is arthritis. And this as a prototype is a young girl, 1 to 5 years is typically the onset. You will have less than or equal to 4 joints. And there is often, whenever you see a joint, you will ask for a history of morning stiffness. And morning stiffness almost always shouts there is some inflammatory pathology. The next thing you will obviously see is there more of swelling or more of pain? Remember, as a rule, when I see a lot of swelling, the swelling comes from the synovium. And a morning stiffness with a swelling which is more than pain almost always shouts a diagnosis of inflammatory arthritis. The next thing you will keep hearing a lot of in today's lecture is the importance of acute phase markers, namely ESR and CRP. So this situation, you will typically have a low ESR and a low CRP. And the only test I would want you to do as a pediatrician is send an ANA in this situation. What's the diagnosis? This is a very classical diagnosis, which is juvenile oligoarthritis. What are the clues? Remember, everything is less. You know, oligo used to be called as posse, so less than or equal to 4. So when the age is less, when the number of joints are less, there is more of swelling and less of pain, and the acute phase markers are less. When everything is on the lower side, clubbed with inflammatory synovitis, you may not wait for 6 weeks for confirming the diagnosis. Just send an ANA by immunofluorescence. 80% of them will be positive, and the positive ANA means you need to be slightly careful vis-a-vis the eyes, because that is a high risk for iridocyclitis. So everything less, juvenile oligoarthritis. So what have we learned? Let's apply on this case. There are 2 kids. One is a 3-year-old male on the left. One is a 3-year-old female on the left and 3-year-old male on the other side. Both of them have left me for 4 weeks. Both of them have morning stiffness, which means that both of them have some form of inflammatory arthritis. The white cell counts are essentially normal on both sides. Platelets are slightly high, like the normal hemoglobin, higher platelets points towards inflammation. ESR is 30 and ESR is 80. ANA is 1 in 320 in the kid on the left, and ANA is 1 in 100 on the right side. So the obvious question is, both have an oligoarticular presentation. Both of them are young age. So which of them are oligoarthritis? The left one, the right one, or both of them? It's so, and what are the red flag signs? I have marked it for you to save time. The kid on the right side has ESR of 80, and history says that there is a history of low fevers in the evenings. So these are some pointers, and obviously what will drag me away from making a diagnosis of juvenile oligoarthritis is this highish ESRs and the presence of constitutional features. One reason where you may start using a Mantoux test, I know Mantoux is getting out of the pediatric dictionary, but a child with a single joint with a high ESR with fevers or without fevers also, please do a Mantoux test, and sure enough, this boy actually had a positive Mantoux, and the biopsy showed caseating granulomas, confirming the diagnosis of TB. So as much as they look similar, do not be in a hurry. The rules are the same, less, everything is less, mostly juvenile oligoarthritis. If there is a high ESR in a single joint, be very careful before labeling it as a oligoarthritis. Another problem with oligoarticular joints, which gives most of us nightmares, is this kind of a child. This is a 5-year-old male who has 2 joints, elbow and a feet, right-sided. But this time, this child does not have a morning stiffness. There is low-grade fever, which is undocumented for 2 weeks. And this pediatrician obviously has listened to us a lot of times, and he said, age is less, joints are less, looks like an oligo GIA. And I see this kid with 3 CBCs in the last 2 weeks. And if you go through this, more or less everything looks normal. HB 9.3, white cells are slightly on the higher side, platelets are fine. Once there was a CRP, which is 1+. So obviously we have inadequate data. And the pediatrician had started this child on naproxen with a provisional diagnosis of oligo, and obviously there was no relief. So this child got referred to me with this blood tests. So as the first thing when you will do, when you're stuck or not, when the things are not going as per plan, you always go and ask the history again. So when I started talking with this family, they said that this child can swim, this child can cycle, but he just doesn't want to walk. And the pain is almost throughout the day. The minute he puts his foot down, he is howling in pain. That's a significant history, because a child who's swimming, cycling, but doesn't want to walk, what's the difference? It's just a matter of weight bearing, right? So that gives you a subtle clue. And the second clue was obviously his child had pain more in the nights as against the morning stiffness that we keep talking about. And the blood tests are essentially normal, but remember the rule, unless I am an infant, I have no right to have lymphocyte predominant counts. Infants less than 1 year obviously have lymphocyte predominance. This child has always been on the higher side. And then when I'll show you the picture of the periarticular swelling, that is very, very classical, right? But, and obviously, if all of us from tomorrow, if you encounter such a situation, please finish the list. Always add an ESR and a CRP to the list. The first time the ESR was sent by me, it was 110. And there was enough of red flags for this child. So please keep entering your answers in the chat box, right? So this child, I said, let's observe on naproxen while we await the reports of the ESR. The father calls me the next day and says that there is an additional involvement of one more ankle, and Ratrabar zhopatats nahi, kaitari kara please. And then I say, just come back and we'll hospitalize this child. I will ask Dr. Nitin Shah to come and do a bone marrow for me. And then I will give him the steroids that he needs, because by now you can see that there is lymphocyte predominance. The platelets have now started dropping. The ESR is in 3 digits and LDH is high. Uric acid is normal. Remember, LDH is not always high and uric acid will seldom be sent in the pediatric literature. Gout does not exist in pediatrics. So if you have a high uric acid, think that you may be dealing with a leukemia kind of a situation. And obviously the bone marrow came and within 1 hour we got the answer. This was acute lymphocytic leukemia. What are the take-home messages from a leukemia perspective? Nighttime pains important. And always remember that, by instinct, we keep saying smear bhej dete hain. A peripheral smear does not rule out a leukemia because the disease, like we know, starts in the bone marrow, which is why the child keeps coming with bone pains. 40 to 50% of leukes will come to the rheumatologist with bone pains. And this golden dictum, if the white cells and platelets are heading in opposite direction, this is heading for disaster. If I have a counts of 30,000, I want a platelet of 6 lakhs. If the counts are on the higher side and the platelets are dropping, or if the platelets are dropping and the ESR is high, start picking up these subtle nuances connected with the nocturnal pains, connected with the suboptimal response to naproxen, and obviously you will never use steroids without doing a bone marrow. This is one image which I want all of you to take home. The articular swelling will typically be, the pointing towards the synovium or the joint capsule. When you see this kind of a picture, you will remember either Shikha or me. But when you see these kind of pictures, which is a full dorsal edema and lot of pain and hardly any swelling, right? This is more of swelling, less of pain is JIA. Or lupus for that matter. No swelling, but lot of pain means you are looking at possibly a hematological manifestation. So what happened to this kid? He was obviously, he was looking sick and he was the kid who was not wanting to weight bear only. And look what happens when I try to, and see what happens when I squeeze his metatarsophalangeal joints. So this is significant bone tenderness. And as much as you would want to think that this could be JRA, because this child actually was referred by Tushar because someone had done a parathyroid hormone and it was a bit plus minus, and Tushar said, it doesn't look my baby, it looks like something like you. And I think it could be JRA because he's wearing a t-shirt. So if you are stuck with your thoughts, start looking at the t-shirt, because your t-shirt, what it says, it seldom is. I'll show you more examples in the subsequent slides. So from the oligoarticular and the googlies, we move to the polyarticular segment. This is a very straightforward diagnosis. When you start seeing symmetrical, large and small joints in the slightly older age group, you will diagnose juvenile polyarthritis. Again, you don't need to wait for 6 weeks. Most of the things are very obvious. Unlike oligo, when everything was less, the polyarticular is everything is more. Usually, it will be more than 8-year-old female. Joints will be more. Acute phase markers will be more. The swelling will be more. And this is a situation will demand only a rheumatoid factor. Sometimes if the RA factor is coming negative and the index of suspicion is high, you may send an anti-CCP, which is more specific for the polyarticular RF positive disease. And if you have an adolescent girl who comes with polyarticular disease, you will probably think that it could be the early presentation of ANA. And you may send an ANA just to round off the list. So the oligoarticular, only ANA. The polyarthritis, you will send ANA, RA factor and anti-CCP. What happens when you have a similar kind of a presentation? So this boy was a 11-year-old male who was referred to me as a suspect JIA, and he was started on methotrexate. The only problem was that he did not look like a 11-year-old. And according to our rule, the ESR should have been high. The CSR was 10. And then he doesn't look like a 11-year-old. And the basic pediatric mind starts to ask proper questions. And as it turned out, he was born out of a consanguineous marriage. And he was very normal till about 4 or 5 years of age. And then the fingers started becoming bent and deformed. And if you can observe, it looks exactly like the previous girl, except that this is supremely symmetrical, but without any inflammation. So I normally call this symmetry with silence. And this is a situation where he is short, and do the basic anthropometry, you realize that he has short trunk dwarfism and not short limb dwarfism. Ask for a skeletal survey and the diagnosis is clear. He's got platyspondyly with some dysmorphism. You will call him MPS, but without a dysmorphism and a slowly progressive deformity without any stiffness, you will start calling him a spondylo. If you do an X-ray of the hand, it will show you epiphyseal dysplasia. A closed differential is a condition called progressive pseudo-rheumatoid dystrophy of childhood. Both of them can be genetically proven. You would do the genetic test, which helps the prognostication, and definitely stop managing this child with immunosuppressants, right? So remember, when you have polyarticular with normal ESRs, could be JIA, but then most likely if you dig deep and you find discrepancies that are mentioned, you will keep your eyes and ears open for a possible skeletal dysplasia in the relevant settings. The next situation in arthritis is very straightforward. Again, no prizes for guessing. You have a 2.5-year-old fever with 5 weeks. He gets exactly 2 spikes per day. So one advice to all the pediatricians from tomorrow is, before you write a prescription for mefenamic acid or an ibuprofen, because this is a season of fevers, please ask for a virgin history of the fever. And the most uneducated parent will come and tell you morning stiffness, and they will say 2 बार बुखार आता है दिन में, fixed time पे आता है. That is the intermittent quotidian fever that we keep looking for. Many times the patient will have 4 or 5 episodes of fever, and the minute you start giving ibuprofen or Meftal-P, the fever becomes quotidian. That is another clue that I am offering you today. A, do not start mefenamic acid, but if you start using Meftal-P in a child who has fever of 2, 3, 4 weeks, by which you have ruled out all the virals and infections, possibly mycobacteria, etc., you will probably get a history of intermittent quotidian fever. When is the best time to see the rash? Is with the spike of fever. This was a young girl who was just scratching. And what are these? These are called as dermographism or Kobnerization. And when you do the blood tests in this backdrop, you will have a low hemoglobin, you will have significant neutrophilic leukocytosis, you will have a very high platelet count. This is a situation which is much better than the previous situation. High counts, high neutrophils, high platelets, high acute phase markers. The diagnosis is very, very obvious. This is a systemic onset JIA. Do not use the word Sjogren anymore. The right word is systemic arthritis, right? For people who have not seen the full spectrum of systemic arthritis, this is the classical salmon pink evanescent rash. Occasionally, you may get urticarial rashes, which increase with the spike of fever. The joint pains can increase with the spike of fever, because that fever spike is caused by a IL-6 surge. This cervical adenitis, or some other day you will see a bicipital tenosynovitis, which is very, very typical of systemic arthritis. And like I said, please monitor the fever before you write an ibuprofen. A 3-4 times fever becoming quotidian is a clue. Or if the virgin fever state is once or twice a day, you will think that it is probably a systemic arthritis. So rash, lymph nodes, arthritis, quotidian fever with or without the joint, and occasionally you may have a PUO with polyserositis, pericardial effusions, pleural effusions. So a fever of unknown origin or quotidian fever for at least 3 days in the last couple of weeks with any 2 of these others features. Document the blood test and remember this picture. Everything is high. Child is supremely inflamed, and this is the right time to throw in a serum ferritin. No ANAs in leukocytosis, no need for a rheumatoid factor, just send a ferritin. How to remember? ESR is 120, CRP is 200, body is on fire, send a ferritin. Easy. What's the systemic arthritis workup look like? Again, do not shy away from sending all of this that are flashing on your screen at the same time. And we keep saying that the hemoglobin is going to be low. So let's ignore the HB for now. The high neutrophilic counts with very high platelets, high ferritin, LDH, LDH of 650, transaminitis, serum fibrinogen, which reflects the ESR of 100, CRP of 120, and triglycerides can be slightly high. Why do I say please send all of them even if the child is not looking very sick? Is if you sit on it for a diagnosis to happen, you may end up with this situation where the 25,000 counts becomes 2,500, the 6 lakh platelets drops to 60,000, serum ferritin keeps on climbing, LDH keeps on climbing, transaminitis increases, fibrinogen drops, CRP 200 and triglycerides are high. What is this? No prizes for guessing. This is a macrophage activation syndrome. So the best way to understand systemic arthritis is think of SGIA when you have intermittent quotidian fever with the evanescent rash, with any of the others, send the full workup and be smart enough to catch them early. And the only way to understand is, let's think the left and the right side of the screen, both of them are the same coin, but two different sides. So once you sit on a very high inflammatory counts, you may end up with an HLH or an MAS. And remember, if you encounter the right side of the screen in your patient, you are also likely that many SLEs and systemic arthritis can start their life with a macrophage activation syndrome-like situation. Get him out of trouble and the actual inflammatory avatar will come over. And this is very easily doable if you think just don't restrict yourself to ferritin or a fibrinogen or an LDH. And the worst thing which will happen is kalsa ferritin, aatsa CBC, udyatsa fibrinogen. Asa nasto. This is very, very protocolized and very, very RTA types. Send urine and electrolytes and ABG and everything at the same time. In rheumatology, when you are suspecting a systemic GIA, send all of these investigations at the same setting to save further dramas. You will never have a presentation from me without this. The importance of ESR and CRP, right? So I do not have any political affiliations, but I think it's high time, whether it is Charsopar, whether it is Abki Bar, whether it is antibody PCR, whatever you may call, please start sending CRP and ESR at the same time. You will never be able to differentiate the difference if you send one of them. And these are the only 4 situations which are possible. A very high CRP, a very high ESR, very, very acceptable for me, suggests an infective etiology, possibly resulting in inflammation, typically serositis. A very high CRP with a low ESR in a sick child is always suggestive of a macrophage activation syndrome. When the CRP is negative and the ESR high, as I'll show you, we always think that it is probably looking at a lupus, rule out malignancy. Last but not the least, when both of them are normal, you obviously can breathe easy. So never separate some things which are always supposed to be together. Beware a 3-digit ESR. We've seen 2 examples now, leukemia. We have seen a systemic JIA. Beware a normal ESR in a sick child. We saw that the ESR can drop fallaciously in a sick child, suggestive of HLH. But as a habit, please start doing an ESR and a CRP together. And if in doubt how to interpret this, you can always make a phone call to any one of us. The next situation of joints is typically, again, a very straightforward kid, 10-year-old boy now instead of a girl, who comes with predominantly lower extremity joints, ankle, knee, hips, and SI joint. He may have uveitis, he may not have uveitis. But again, when you have a boy, you will never send an ANA, RA factor, anti-CCP, etc. Only one test. You will always send an HLA-B27 and you will label him as an enthesitis-related JIA or a spondylitis-related JIA. The clue, B for boy, B for below the waist joints, and B for B27. And some other day, if you see a kid from the hinterlands of the middle part of India, so typically UP, Bihar, Bengal, so B. view and the joints are the lower extremity joints, please send an HLA-B27. The only condition is no flow cytometry. It's always going to be by PCR method, right? And sure enough, many of these kids will end up having sacroiliitis also. So the final type of arthritis which can come to the OPD will be typically a 7-year-old female. This girl actually came to me from the hand surgeon, and the hand surgeon, the kid's parents approached because the finger was swollen, and then he ended up having a biopsy, and the biopsy came back inflammatory. So the room reference was made. And this is a very typical situation which is called dactylitis or a sausage digit. And the only question you will ask in this kid is, does anyone have a skin problem? And sure enough, this girl had what was labeled as dandruff. And on a closer examination, this child also had a small scaly patch underarms. And then this actually turned out to be, again, easy to judge. This is a psoriatic arthritis or flexural psoriasis. And then the history came that Nana also has a florid psoriasis, right? You could have diagnosed this only by asking the psoriasis question. And why did I ask the psoriatic question? This is again a trade secret we are leaking out today. When you see a single digit for 1 or 2 weeks, think that it could be my bacterial infection. 2 to 6 weeks, always rule out a mycobacterial more than proving it. Beyond 6 weeks, you will invariably be hitting at an inflammatory synovitis. And with some luck, you would be looking at a psoriatic arthritis-like situation. These are different pictures where this child came with the similar story, and this actually came with an oligoarticular presentation. And then remember, psoriatic arthritis can also present at the oligoarticular age group. And actually, when you undress the kid and check, be very, very smart enough to examine, undress the child. This child actually had a peri-umbilical plaque of psoriasis, right? So this was a kid I saw last week. This child came with just this finger, which was a bit bent. But more importantly, when you examine this child, actually had a diagnosis of psoriasis by a dermatologist, and this finger started bending. So in a way, this child was lucky enough to have this patch very obvious, and then the joint, and then the diagnosis was very easy. You don't need to biopsy, or you don't need any fancy tests. So from the arthritis, let's move on to the next set of group disorders. So this was the vasculitis group, as I call. So a 13-year-old girl who actually came to me with a fever on and off for the last 1 year. And nothing great about it except that there was significant headaches, backaches, body aches, and she had lost 5 kilos. And this was her CBC. So we are always looking at the counts were slightly high. ESR very surprisingly was done on all the occasions, but people could not figure the cause of the high ESR. All 4 ESRs were very high. So what's the thought? Why should the child have a high ESR and a weight loss? It was pointing to a systemic process. This child was worked up for SLE and other things. She was getting better with some NSAIDs, etc. But the reason she came to me was there was significant backache which started increasing. And this is a situation when you don't have any clues and ANA, C3, everything has been done. Just put your finger on the pulse, and sure enough, you could not feel the right-sided pulse. And there was a systolic blood pressure discrepancy of more than 10 millimeters. I repeated the blood test and ordered imaging. And then, before I show you the images, just to revise the 3-digit ESR causes. If you see a 3-digit ESR ever in the OPD, most common thing you will think of is tuberculosis in a chronic history. In a short subacute to chronic history or acute to subacute, you will rule out a leukemia. But beyond that, it's probably a form of vasculitis or a systemic JIA, like we saw in the previous story. So almost all the blood test that I'm showing you is very, very resembling the systemic JIA part of it, except that this child never had any features to suggest a systemic JIA. Right? So what did the imaging show? This imaging came back with the best, or probably not so good for the kid. There is a nice tapering aorta, and the subclavians were all narrow, the internal carotids were narrow, and These days, this is obviously shouting a diagnosis of aortoarthritis. The iliacs were narrow, the renals were invisible, and these days we go one step ahead and start doing a PET scan or an FDG PET, which actually picks up the activity of the disease on a PET CT or a FDG PET scan. So when you have an unexplained high ESR, a simple thing, document a blood pressure discrepancy or a pulse discrepancy and diagnose Takayasu arthritis. As against this child who presents with infarcts, gangrene, you can see a little bit of ulnar claw setting in, livido reticularis, erythema nodosum, and the history will typically be high PUO, high CBC, high ESRs, and all of this melena, orchitis. This is a very tailor-made situation. You will start thinking of a medium vessel vasculitis. More specifically, you are looking at a polyarthritis nodosa. The third situation is, again, no prizes for guessing. This is a small vessel disease. Palpable purpura. Sometimes you can have a bullous lesion, testiculoscrotal involvement. Again, this is straightforward IgA vasculitis or HSP as it used to be called as. This situation without fever is HSP, most common. But because we are in Maharashtra, anyone from Solapur will shout, "Arey, with fever hai to rickettsia." And I would like to quote Dr. Atul Kulkarni, HSP with fever, rule out rickettsia as a dictum, which makes a lot of sense. And the last thing is, once you ruled out these two, remember rheumatology can also present with these kind of leukocytoclastic or small vessel vasculitis, but rule out HSP, rule out rickettsia, and then think of the rarer conditions. So what's the take-home message vis-a-vis vasculitis? Large vessel vasculitis, the pre-pulseless phase of Takayasu is often missed. And that's the problem. And you have to have a very, very high index of suspicion and a low threshold to investigate. So unexplained body aches, claudication pains, non-specific systemic symptoms, significant weight loss, a child presenting with posterior reversible encephalopathy, hypertension of unknown etiology, congestive cardiac failure, a child who just comes crashing in heart failure. Eyes can sometimes give a clue. Not frequently do we hear this word called scleritis, right? So scleritis with all this and high ESRs with no reason, think of large vessel disease. The medium vessels relatively gives enough of clue if you are smart enough. Fever of unknown origins with this infarcts and gangrenes and nodules with multi-organ involvement with neuropathy. Think of PAN. The small vessel is very, very easy to pick up. Then the only job that we have is to figure out the cause, right? So this is vasculitis, right? The best way to understand vasculitis is you start seeing a lot of things. It's a small vessel disease. You start seeing bad things and trying to understand what is happening. Because of the complicated nature of presentation, you are looking at a medium vessel disease. The most dangerous is the silent killer, as I call it. Takayasu can be missed, and then you will end up with, a lot of trouble later on. So it's more about, connecting the dots, take a good history, get the examinations and start thinking in terms, once you hit cross 4 to 6 weeks, in terms of rheumatological conditions, which can, we'll take all the questions at the end to save time. This is an exception. You will probably not see this kid in the future, but I thought I should share this. This was a kid who was diagnosed as Crohn's disease with very high ESRs and CRPs. And the reason this kid came to me was while the child was getting worked up for Crohn's, a CT scan revealed a superior mesenteric artery dilatation. And then this child developed a greater saphenous vein thrombophlebitis. And then when I examined this child, the reference was because the SMA was not explainable by the Crohn's. And then when you start examining this child, you have an arterial involvement, you have a venous involvement, and you have this folliculitis-like lesions. And you start connecting the dots. The vasculitis we saw till now was purely arterial or predominantly arterial. This is a situation where you have an artery and a vein and these pustular lesions. And then the only thing you will do is just take a 24 gauge needle and stick it on the forearm. And what I'm referring to is somewhere lying in our textbooks called pathergy phenomenon. So pathergy test with this combination often points to a Behcet's disease. And when we image this child, I just wanted to see what else is happening, and all other blood vessels also came up, including the arch of the aorta, the descending aorta, the abdominal aorta, the left subclavian, and the carotid. So this is a very rare exception. This was a vascular Behcet's, and this child has not had a single aphthous ulcer or a genital ulcer. So the clues, when you start connecting the dots, had a GI involvement and an arterial and a venous. It may not strike you immediately, but at least if you are doubting anything, it's always good to think of a rheumatological cause, because why should you have this kind of a presentation, right? And again, if in doubt, please phone a friend. Some of us will be able to help you out through this. The penultimate session is on connective tissue disorders. And this, as a rule, sums up all the typical signs of connective tissue disorders from head to toe. Starting from the head to the toe fingers. I'll show you the pictures to save time. So the classical alopecia of lupus to the malar rash of SLE, vasculitic lesions can happen in either a vasculitis or lupus or a dermatomyositis. When you start hearing scleritis, episcleritis, be on the watch, because that could potentially mean a CTD in evolution. Hard palate ulcers, very, very specific for lupus. A dermatomyositis will often have a heliotrope rash. The dry mouth, I'll show you to a case. Infarcts and gangrene could be the presentation of a vasculitis or an SLE. This we have already seen as a infarcted medium vessel vasculitis. HSP-like rash can come in a connective tissue disorder also. The Scholl sign, the Gottron's papules, and vasculopathic ulcers suggestive of juvenile dermatomyositis. And this slide, I think, is very important because there are certain patterns in a suspected connective tissue disorders which definitely will lead you to a potential diagnosis. I will not read each line of it because it will be probably saved for viewing later on, but there are certain markers which I'll run through the cases. So this was a 7-year-old girl who presented with periocular swelling since 3 months and fever on and off since 1 month, and she had severe constipation. So there are enough of clues that this child came with. Both the eyes were swollen. So obviously it is not an infection. Why should a 7-year-old run fever for a month? And why should she be a girl? Enough of clues. The minute you start thinking of a girl with fever for a month, I think before you think of TB, at least think of ruling out an SLE-like situation. Why should a 7-year-old be constipated? So enough clues. And when you do the blood test, HB is low, counts are low, lymphopenic leukopenia, and low platelets, thrombocytopenia. So almost a lymphopenia with pancytopenia. This is shouting the diagnosis. Open her mouth and you see hard palate ulcers. Underneath your IV line, IV पट्टी घातल्याने इथे दुखतो किंवा सुचतो, बोट दुखत नाही. She had arthritis or dactylitis. And then obviously what comes to my rescue always is an ESR and a CRP. A CRP was negative and the ESR is high. This situation, please remember, in a girl who is inflamed for a month with a negative CRP and a high ESR, with leukopenia, thrombocytopenia, and anemia, you will send an ANA which came positive, and all the diagnosis was confirmed that this was a lupus. What do I want the pediatrician to recognize is the girl part of it, the fever part of it, and the low counts and the negative CRP and a high ESR. Once you see this, you will screen by doing an ANA by immunofluorescence. You will send a C3 and a C4 which should be low, and you will send a urine protein creatinine ratio which in SLE patient should be less than 0.5. Do not wait for PC ratio to go more than 2. More than 2 is nephrotic in the nephro literature. In rheumatology, a PC ratio of more than 0.5 means you are in trouble, right? And as a part of the lupus workup, I always send a thyroid profile, and her TSH was supremely high. So a patient with lupus will often have autoimmune hypothyroidism, which was actually causing the constipation. And once your screening comes positive, then you can confirm the diagnosis using the ANA blot. When will I think of lupus? Always think of lupus, screen, and then you will confirm. So female fever fatigue, we all know that if you don't need to have the butterfly rash, we've seen the manifestations that SLE patients can. Always think of lupus, start opening the mouth. As pediatricians, we see the tonsils. As rheumatologists, we see the dental cavity for any thing suggestive of an AML, or you will look at the top of the palate for hard palate ulcers, erythema, hair fall, systemic features, weight loss. And this arthritis in lupus is typically non-deforming. You may think if a child who's an older age group comes with nephrotic syndrome, you will always think that whether she is an SLE as a primary disease. Anytime the hematologist starts giving you a diagnosis of chronic ITP or EVAN syndrome, autoimmune hemolytic anemia, these are situations which will warrant at least an ANA before crucifying them to a platelet count of 20,000 for the rest of their life. Chronic ITP, please rule out lupus. Unexplained encephalopathy, psychotic behaviors, chorea, involuntary movements. As a PG student, Sydenham's chorea is the first. As a practicing pediatrician, you will think lupus is probably more common than rheumatic chorea. If in doubt, recognize these features, document lymphopenia, document thrombocytopenia, negative CRP, high ESR, screen with ANA, C3, C4 and urine. Once they come positive, low complements, proteinuria, confirm with an ANA blot or phone a friend. Quickly, 2 cases, both of them was referred as HSP. And again, the messages start looking at what the kids are wearing. Both these kids looked HSP. I think HSP is probably the coolest disease that most of us manage, because as bad as it looks, it gets better most of the times. But then the merit of doing an ESR and a CRP together, both the ESRs were high and both the CRPs were negative. Is it lupus? Possibly, because the left side was a girl, the right side was a boy. Doesn't mean they can't have lupus, but the history was very going on in the left side for 3 years with only the rash. In the right side since 6 years. And then now the kid on the right has joint pains, and the kid on the left was labeled as silk allergy. And this ESR was actually sent by a dermatologist. So recognizing the patterns, the ESR is high in both. And the boy on the right side actually got to a medical college and the biopsy of the lesions were done. It was showing small vessel disease and it was said that it is HSP and go home. But what was failed to recognize was the ESR, which was in 3 digits, the total proteins which were very high. Remember in life, whenever you see very high proteins, think of a condition called as hypergammaglobulinemia. Then you start connecting the dots. When you have high proteins with high ESR and the lesion is in the foot, always look for clues. The problem is in Kerala, look at Kashmir is my usual dictum. This child with silk allergy had red eyes, which was labeled as allergic conjunctivitis. And the kid on the right had severe dental caries. Why should a 10-year-old boy have dental caries? So remember, red eyes and so this boy actually also started having parotid swellings. So you start connecting the dots. The take-home message is red eyes with high ESR equals a dry eye and dental caries, severe dental caries in a 10-year-old with high ESR with hypergammaglobulinemia. You will remember reading a condition called Waldenstrom's hypergammaglobulinemic purpura. And all of them point to only one condition. Remember, Sjogren syndrome is a disease of a 55-year-old, not a 5-year-old. So a 5-year-old will give you enough clues to think of Sjogren and we diagnose Sjogren. Take home message, red eye could be a dry eye and dry mouth could be suggestive of Zika syndrome. So ask the dentist and the eye doctor for specific things and you may get clue. No prizes for guessing. I'll run through this quickly. People who have not seen, this is a classical heliotrope rash. This is the Gottron's papules, which can also be seen on the knees other than the knuckles. Vasculopathic ulcers, see the muscle wasting. When you start seeing this, identify the pattern, test for all the 4 muscle enzymes, CPK, SGOT, LDH, and aldolase, and confirm the diagnosis using a stir MRI. And confirm the diagnosis on a stir MRI as juvenile dermatomyositis. For people who have not heard this before, how do I differentiate between a lupus butterfly and a JDM butterfly? The sparing of the nasolabial folds often suggests lupus, whereas the JDM butterfly crosses the full bridge of the nose. There are other signs that, like you have the gotrons. If you see the gotrons on the inner side, you call it inverse gotrons. Rarely seen, but if you start seeing inverse gotrons, please phone one of us. That's a high risk marker for significant disease. And if you do not treat these kids aggressively, you will end up with a lot of complications. One such complication is you don't want calcinosis cutis or dystrophic calcifications in the subcutaneous tissues, right? Let's move on. The last kid who we would probably cover in the connective tissue disorders is this kid who I saw when I was training back in Perth. And this was a kid who came to me because she couldn't play tennis because of some skin tightness. And if you examine, this has been going on for the last 1 year, and you could see that the one extremity is thinner than the other. This is a classical condition called linear scleroderma. Now, if you are lucky, you may see this kid because most of them end up with the dermatologist and a lot of time gets wasted. But if you see a linear, shiny, tight skinned patch, you will diagnose linear scleroderma. And you may be unlucky to encounter this kind of a situation where there are isolated patches of thick skin and it's diffusely distributed with bad vasculitic ulcers. And you will diagnose a diffuse morphia in this situation. And this is a kid who, in the same family, came with, like the previous kid, came with contractures without any stiffness. And then the AC in my consulting room, I just asked her to wait for 5 minutes till I finished the rounds and came. And sure enough, when I started seeing bluish discoloration of the palms and soles. And when you look at the nose, there's a slightly pinched out nose and very, very symmetrical, but hardly any stiffness. So what can cause a stiffness without any arthritis is the skin getting tight. And this is nothing but Raynaud's phenomenon. When you see Raynaud's plus a tightened skin, you will start thinking of a possible scleroderma, except that this will be a systemic scleroderma. And when you send an ANA blot, you will test positive for an anti-SCL70 and you will diagnose juvenile systemic sclerosis. You know, many people keep asking ANA bhejne ka ki blot bhejne ka. Important slide. First, you document an ANA. The ANA will pick up if the child has an antibody against my own nucleus. What the blot will tell you is which antigen in the nucleus is the ANA directed against. So, for example, the ANA directed against dsDNA suggests lupus. Against a Rho or a La suggests a primary Sjogren, so on and so forth. So, if the ANA is negative, I may not send a blot. And if you have a blot that is flashing 5 antibodies and the ANA is negative, I think it's time to change the lab rather than change the diagnosis. So, the bottom line is document ANA by immunofluorescence. And once the ANA comes significantly positive, then send the ANA blot, and then interpretation of the blot becomes easy. So the last part of my talk is something which is an overview of what all of us are going to see more and more with increasing awareness. When I started practicing about 10 years back, I used to get away, माझ्या बाळाला हे काय झालं, idiopathic झाला. But then from idiopathic post-COVID especially, we started using terms like innate immune system suddenly has come to the fore, inflammasomes, interleukins, interferons, and we started using these kind of terminologies. What I'm going to speak in the next 5 to 7 minutes is a group of disorders which are called inborn errors of immunity. We heard of IEM. Now we'll hear about inborn errors of immunity or autoinflammatory disorders. So this slide is just to sum up what's the difference between autoinflammatory and autoimmune conditions. Remember, autoinflammatory, autoimmune, and primary immunodeficiencies are all problems with our immune system. The autoinflammatory is a problem with the innate immune system, which means the problem is either in the dendritic cell, neutrophils, macrophages, complements, etc. The autoimmune, as against the innate immune system, is primarily a problem in the T cells and the B cells of the body. And when none of them function the way they are supposed to, you will probably start thinking in terms of a primary immunodeficiency syndrome. One group of disorders which now we recognize as probable autoinflammatory is what used to be called as periodic fever syndromes. But as we keep understanding more and more about it, these need not be periodic, and it's important to recognize the patterns. I'll just show you 3-4 cases, and then we'll probably sum it up in the end. This was a child. Do we have time? It's just about 10. Can I go ahead?
Yes.
Yes, sir. Yes, you can.
So this was a kid who was referred to me at age 5 with a history of fever since infancy. So 8-9 months, this child started running fever, and this pediatrician was extremely smart enough to pick that there is something in the joints, and he said, it's your kind of a story. And when I start observing this child, he actually has this kind of a skin. And again, no prizes for guessing. Parents ने भी बोल दिया कि सूखा है उसका skin, गर्मी में ज़्यादा हो जाता है. But then the medical word for this is ichthyosis. And then the problem is, remember, the problem is in the leg, start looking into the eyes. And when I flashed the torch in the eyes, you started seeing these festooned pupils to your naked eye. You don't need an ophthalmologist. And I start connecting the dots. You have a festooned pupil suggestive of chronic uveitis. You have a ichthyosis, and you see the joints. Remember the slide on leukemia I showed you. This is very, very articular and not periarticular. And the word I'm going to tell you is this is called as a boggy tenosynovitis, a boggy synovitis or a bulky synovitis with a skin, with an eye. I send him to the eye doctor, and the eye doctor shouts and sends me this picture. And he says, this boy has the world's best mutton fat capies, which we have read as a sine qua non feature for sarcoidosis. And the way to remember, can sarcoid happen at such a young age? Yes, it's called as infantile onset sarcoid, also called as Blau syndrome, right? It's again one of those rare conditions, but I have got 3 patients of Blau syndrome, and all of them have come up from Maharashtra. Remember RAU, rash, arthritis, and uveitis. When you see RAU in a young age child with bulky synovitis, you will diagnose BLAU, that is Blau syndrome, right? Unlikely to encounter, but not impossible, right? This is another kid who I had seen during my training. This was a 4-year-old boy who kept on getting fever. Do the blood test. He will look exactly like a systemic onset JIA. But every attack of fever lasted only for 1 to 4 days, severe abdominal pain, and all the USG showed was minimal free fluid. And this child once came with a pleural effusion and used to get better by the time the workup came back, right? What looks like SOJIA, erysipelas-like rashes, not an evanescent rash, but typically lasting 1 to 4 days with sterile polyserositis. You will call this as a familial Mediterranean fever, which can be checked because it's a monogenic disorder, right? So 1 to 4 days fever with rash, with sterile polyserositis is FMF, right? The next situation is, again, this child actually started running fever from day 14 of life, and urticarial rashes. And when you see this child, sometimes it's the wrist, sometimes it's the digits, dactylitis, lymphadenitis, and urticarial rashes. And this fever lasted for 7 to 10 days. 7 to 10 days, but what was common was the skin and early onset of a febrile illness with arthritis and or lymphadenitis. And this child used to get additional features like diarrhea. So when you start seeing this kind of a feature, you will start thinking of a periodic fever or an autoinflammatory. And the more you start reading, you will come across this condition called hyper IgD syndrome. I do not expect the pediatrician to diagnose hyper IgD. All I expect is to start recognizing the infantile onset of a febrile prodrome and start connecting all the clinical features, right? This again is a rarity. He starts running fever from 6 weeks of age with urticarial rashes. And when I saw him, what looked like a joint, actually, when you do an X-ray, it looks like a rickets. You don't get rickets at such a very young age, but you start seeing this patella. It's actually a patellar erosion and bony erosion. So this is a patellar inflammation. When you start seeing infantile onset fever with a rash, with this prominent jutting out patella, this is a picture I just borrowed from Google, and this is what happens if you do not address this issue on time. So the people who are practicing in NICUs, if you have an infant who's running fever with a rash, once you're done up with the septic arthritis, you do a eye check, you come across with retinopathy, or you do a hearing assessment, and this child is hard of hearing and his ESR is high, start thinking of a autoinflammatory condition. This condition is called chronic inflammatory neurocutaneous articular syndrome, also called as SINCA syndrome. Rarity, you may never see it, but this patella is something which is very, very eye-catching, right? And if you do an X-ray of that patella, you will see rickets-like changes. The last of this type is, again, this is a child who was running fever, but this fever used to go for 3 to 4 weeks. He changes 3 to 4 pediatricians, and the fourth pediatrician gets lucky and the fever goes away for 2 to 3 weeks, and again it starts running. And this parent came, Sapa Sarka rash eto. And Sapa Sarka literally translates to a serpiginous rash. And to the rheumatologist, this is a very straightforward diagnosis. Serpiginous rashes, fever going on for 3 weeks, and 4th week the fever goes away. In the setup, and when she gets fever, her eyelids start swelling up. She has these rashes, and when she's normal, she's absolutely normal. And this is a condition called TRAPS, or tumor necrosis factor receptor associated protein syndrome. So 1 to 4 days is FMF, 7 to 10 days is hyper IgD, 4 to 6 weeks of fever could be TRAPS. Remember, if in doubt, ring us up and we will be able to help. Easy. Again, a rare disease. This child was referred as a suspect systemic GI at age 2 years of age, and everything looked like SOGI, low HB, high counts. And the pediatrician had started this child on steroids, and this child was spiking at 10 mg steroids also, a young child. And then when you start revisiting the history, this actually the parent showed me this video, and I'm using it with permissions. Please do not share this with anyone. This child, you notice, had 2 episodes of Bell's palsy, one at 5 months and one at 16 months. When you start seeing the rashes also, this child actually had livido reticularis. And then why would this, if you notice, there is a slight deviation also. So there is a facial and a paucity of movements of one of the sides. So there is possibly some hemiplegia or something to suggest a weakness along with the cranial nerve. And then you start connecting the dots. And in rheumatology, when you start seeing such things, you will start thinking of an autoinflammatory disorder involving the blood vessels. So you will come across on an exome sequencing a condition called deficiency of adenosine deaminase 2, or what is also referred to as a monogenic vasculitis or a polyarthritis. And this is a child, once you started her on a TNF alpha blocker, is doing very well. So take home message from the autoinflammatory part is, when will I remember that these things do exist in your OPD. Systemic arthritis-like features like we saw. What is most important is people in NICU have to be very alert. If they are seeing an infantile onset or a neonatal onset of a febrile illness, and I always remember or teach calling it SSC examination. What is SSCE is synovitis, serositis, cutaneous, and ice, either isolated or in combination. This child may be quiescent in between the attacks in the periodic fevers, but in the other autoinflammatories that we saw may have a continuous fever. Try to recognize the patterns. Many times there may be a kid who gets recurrent episodes of osteomyelitis, unexplained strokes. You image the child and see calcification without a reason, and then you dig out the history that more siblings are affected, unexplained developmental delays with inflammatory markers high. Occasionally, some kids can have recurrent HLH going on. That's also a clue. So keep your antenna up for these kind of conditions. And then there is enough of literature for people to read and get wiser. So SACE is probably the take-home message. So to conclude, what have we learned today? Age is less, joints are less, girls more than boys, acute phase markers are less. Send an ANA, screen for the eyes, diagnose juvenile oligoarthritis. The same kid keeps adding up more joints, you will end up diagnosing an oligo extended or a rheumatoid factor negative polyarticular if she adds up the joints. An adolescent female, age is more, joints are more, markers are more. Send an ANA for lupus, send a RA factor for RF positive, diagnose juvenile polyarthritis, RF positive disease. But when you have a boy whose age is more and typically lower extremity joints, dactylitis, sacroiliitis, you will invariably send an HLA-B27 by PCR and prove a diagnosis of enthesitis-related arthritis. A PUO in your OPD, document quotidian fever with or without the rash and the combination of HS megali, polycirrhositis, arthritis. You will pick up the anemia, significantly high neutrophilic leukocytosis, very high platelets, send a ferritin, no role of ANA, diagnose a systemic arthritis. The converse we have seen, do not fail to pick up a mass, get them out of trouble and things may evolve. Lastly, full HLH workup at the same time. Do not compare yesterday's ferritin with today's CBC and tomorrow's acute phase markers. When it comes to vasculitis, any unexplained fever without a focus, with or without constitutional features, claudications, press, congestive cardiac failure, put the finger on the pulse, document BP discrepancy, image, diagnose Takayasu. Winters, we all know Kawasaki. I just had one slide without pictures. We might need a separate session on Kawasaki at some point of time to clear off some myths and misconceptions. The fever of unknown origin with hypertension, infarcts, neuropathy, and high markers, do an angio, diagnose PAN. We all know HSP, how to diagnose HSP with fever, Solapur, rickettsia. Once you ruled out rickettsia and HSP, start entering the world of lupus and Sjogren and ANCA, etc. I have shown you the signs. You could pick up dermatomyositis, see the signs, send muscle enzymes, document edema of muscles on MRI, diagnose JDM. The female always has to be a lupus to be ruled out. Once you recognize the pattern of symptoms, anemia, lymphopenia, negative CRP, high ESR, and a proteinuria, please send an ANA blot and confirm and refer this child for proper care. The new thing that we learned is autoinflammatory syndromes. These do exist in our day-to-day OPD. We may not be able to diagnose all of them, but at least for 30 to 50% of them will end up having a proper genetic diagnosis. The red flags are early infantile onset of febrile illnesses with the SSC examination that I said, and consanguinity often has a role to play because many of them are autosomal recessive. And if you start seeing unusual features like recurrent episodes of HLH or MAS in the same child, think that there is something happening which needs to be interrogated. So again, no political affiliations. Even if you forget everything that I have spoken in the last 1 hour today, remember that when you are stuck, double engine will come to your rescue. What's the rheumatological double engine? You will stop looking and start seeing for subtle clues. The odd patient out of the 200 kids that we see in the OPD will show you enough clues. We all hear what the patient says. Start listening to what they are saying. Swimming karta hai lekin chalta nahi hai is one example. If you don't have the time to see and listen, please send a CRP and an ESR and WhatsApp me. Please do not call me after 9 o'clock. I may not be reachable. But bottom line is, it always has to be ESR and CRP together before you WhatsApp. Ram Gopal had actually said, Vijay, think of Vijay, remember Amitabh Bachchan. Now the chat box is completely open for the non-scientific stuff. Each one of you will start labeling which movies. For trivia, Amitabh Bachchan, I have leased my name in 21 movies, and these are the more popular ones. Where I'm coming from is they all look the same. So when you see a joint, you will remember not Amitabh Bachchan, but a rheumatologist. And then what we need to do or we need to understand is 1 hour of this lecture is not going to convert all of us overnight. You will find it very easy now, but tomorrow morning everything gets forgotten. Keep visiting these PowerPoint presentations. Start reading about what we have discussed. Start recognizing pattern. Keep revising it and repeating it. I'm sure the chat box is full with all the names. Zanjeer, Shahenshah, Agnipath, etc., etc. Again, why do we remember all of them better than what we had for breakfast today morning? Is because of constant exposure. All of us grew watching only this. So keep doing the same again and again and again, and you are going to get better at whatever you do. I will end myself over here and hand over the stage to the organizers. Thank you very much.
Thank you so much, sir. Thank you for an excellent session. And I think people are all hooked up to the screen as yet for till around 10:15 also, because of the excellent and easy that you make the sessions with your presentation. So I'll take up the questions. So first question, the one question that we had in between is, when you were presenting the dactylitis case, that how do you differentiate with spina ventosa? Dr. Balmukunda had asked a question.
What from spina ventosa? Yeah, okay. Dactylitis. Yeah. So it's always a... Sorry.
Other than taking a potential diagnosis of dactylitis, if we can give it.
Yeah, I think it's both of us agree that it's always a story of how the child presents. The first 2 weeks, usually the commonest thing will be a bacterial infection. 2 weeks to 6 weeks in India, you will always think of a possibility of a mycobacteria causing something like a spina ventosa, etc. But it's just a matter of the purpose of showing that slide was, if you see a dactylitis, before good old days, we used to do a Mantu at least. These days, we don't do a Mantu. If it comes positive, we don't believe in the Mantu. And the purists don't believe in TB gold also. MRI will probably be non-conclusive. The only one take-home message is ask for a history of psoriasis or anything to do with the skin in someone who has a chronic synovitis going on for 4 to 6 weeks involving 1 or 2 fingers. You may get a history of psoriasis. You may get a history of something to do with HLA-B27, ankylosing spondylitis, acute anterior uveitis. All of them. Remember that even psoriatics, 20 to 30% can be driven by a B27. So difficult to diagnose clinically, spina ventosa versus a psoriatic. The idea is to rule out, and the best thing about rheumatology is you often end up diagnosing many rheumatology patients by ruling out rather than trying to rule in a particular disease. I hope I answered that question. Do you have any other explanation?
More of destruction. There is more of destruction which happens with if it's spina ventosa. So if you see a normal X-ray also, or if you end up doing an MR, the psoriatic arthritis, dactylitis will not cause as much destruction of the joints and the bone as a spina ventosa. And maybe, sir, a hematological condition which always should be remembered when you see dactylitis, usually acute, that is a sickle cell anemia. So if you see a dactylitis, which may be not as acute as we always think that a sickle cell would be, and of course hepatosplenomegaly. So you gave good DDs of dactylitis. You covered hyper IgD syndrome. You covered psoriasis, spina ventosa. So next time any pediatrician sees a joint, the finger joint swelling, they will of course remember you and all these symptoms. Okay, so we have another question, sir. When to consider CRP ESR raised? Is there any grading for level of increase?
Who's asking the question? Sorry.
Some Dr. Patel TT.
Okay. So the first thing is start doing ESR and CRP. And there is no fixed values. The idea is with experience and the more you start seeing, it's about picking up discrepancies. So for example, if I have a CRP of 150 and an ESR which is only 40, and you club it with the clinical condition of the child, I know that CRP climbs up faster and climbs down faster. ESR is slow to climb up, comes down slowly. But somebody who is critically sick in the ICU with a normal CRP or a very high CRP and a ESR which is discrepantly low, that is a problem for me. Versus a 10-year-old girl who has a who's very sick, but a CRP which is negative and an ESR which is 120, that to me is SLE unless proved otherwise. And if both of them are high, is probably what you're going to encounter. But then even in that, if I'm seeing currently a child whose CRP is 400 and the ESR is only 58, that is a problem for me, and that is obviously shouting that this is a child whose WBC count is about 4,000, whose platelet is 20,000. So that is straight away taking me to HLH. Where I'm coming from is, do not dismiss an ESR as being non-specific. Not doing an ESR is a bigger crime. How to interpret it is, you are going to just remember, see that slide that I have put up in the talk. See daily when you go for your OPD. You may need to keep, it next to your prescription pad and start interpreting this in the context. 1 day fever, CRPs are normal, could be viral. 2 divsa devun beta. 1 day fever, CRP is 150, ESR is normal, could be bacterial. Start hunting for a otitis or a tonsillitis or a bacterial infection. 3-4 day history and ESR is 45, 50, 60, CRP is negative. You know that there is some inflammatory mischief happening. Cut the answer short, no fixed values. The idea is not to take individually, but to see both of them in totality and then interpret in the clinical context. And how to interpret, if in doubt, you either ring up Shikha if it's 9 o'clock in the night. If it's 9 in the morning, you are most welcome to ring me up or WhatsApp me. I hope that
So very
answers the question.
Yes, very beautifully covered. So basically, Dr. Patel, if you're hearing us, then the major thing is what sir wants to focus is do both of them. There is no specific level of increase that we can see. But if you see both going hand in hand or both going in opposite directions, think of differentials accordingly. To summarize, so if I can take a few questions, if I would like to bust the myth, I would like you to bust the myth about two things. One is HLA-B27, because always it's thought that it will happen only in males. So one is that, and lupus, which is thought that it will happen only in females. So, but in pediatric age group, I'm sure we see a lot of difference in this only thing.
So all the pediatricians are well trained in the dictum, diseases haven't read textbooks. Good old Amdekar sir's teaching. No reason why a girl should not have HLA-B27. No reason why a boy should not have SLE-like disease. Having said that, the purpose of today's lecture was more to sensitize the newer pediatricians to the more classical situations. And the idea is just to recognize pattern. If you have a 10-year-old girl instead of a 10-year-old boy who comes with a sacroiliitis, it is but obvious that I will think of a possible HLA-B27. And believe you me, I have got 5 families where girls have giving HLA-B27s to their boys. The mom has B27 and the son has B27. There are situations like that, but that's an exception and not the rule. But the idea is to be, a bit alert to the possibility of what could be the reason. And a boy who has a negative CRP ESR 120 with palatal ulcers would obviously be a boy with SLE, which is more of a problem. So recognize the clinical pattern irrespective of the gender. The gender would probably lead you to the chapter of the book. But beyond that, to reach the paragraph or the word, you will probably need to use a little bit of fine-tuning skills, which and obviously when you're thinking of lupus and asking for an ANA, do not cut costs. Please specify indirect immunofluorescence and not ELISA, number 1. And when you're asking for an HLA-B27, do not ask for a flow cytometry to cut about 500 to $1,000. It's always to be done by a PCR method. And only when the index of suspicion is high, you will send both of them and then to interpret them in the right context. You may confirm a lupus with a blot or you may confirm HLA-B27 if the other features come through. So no hard and fast rules, but recognize the pattern is all that's important.
Thank you, sir. So if you have time, so one more thing. So normally if I once myself Googled what is the commonest test that what test you should do for joint pain. And it actually told me anti-CCP. So
Nice.
because one of my patients did it and came and said that Google kiya tha, ye aaya, to main karke leke aaya hu. So would you like to again clarify things about anti-CCP? When should it be done?
I envy you for practicing in the more affluent part of Mumbai, where all the patients would probably not mind spending 3,000-4,000 rupees. So as a rule, anti-CCP definitely in the adult rheumatoid literature is very, very specific for a erosive arthritis. In pediatrics, because we are conservative, we assume that the patients are poor for a start. And obviously there aren't enough studies to validate the specificity of anti-CCP in the younger kids, let's say a 6-7-year-old with polyarthritis. But remember that 80 to 85% of what looks very, very JIA polyarticular, the way I described, could still be positive only in 85%, 80 to 85%. 15% of them will still be negative, and that 15% is probably the one where I may stick my nose out and say this child needs an anti-CCP, because if that anti-CCP comes very, very strongly positive, I would probably be confirming. So the CCP is specific for erosive arthritis. That's our ultimate purpose of sending even an RA factor. If you treat, you may get dramatic results early on. If you sit on it, you will probably end up destroying the joint. That's the whole story. So clinical suspicion, send a rheumatoid factor, confirm RA factor. Remember even that RA factor, the commonest cause of RF positivity is a false positive. That comes with its own set of fallacies. So if you are sending it, send both of them in the right context. If RA comes positive and CCP comes negative, fair enough. If CCP comes positive, RA comes positive, ideal situation, marriage made in heaven, confirming the diagnosis. If only CCP comes positive, RA comes negative, you may need to just discuss it with someone who's seen a bit more of what's happening. Not to be sent in every kid is the short and sweet answer with polyarthritis.
And more value. RF is more of a prognostic value rather than diagnostic.
Yes.
So you have questions on the chat box. So when do you think that there can be a monogenic lupus?
So you will start suspecting. I'm trying to get the chat box on. 1 second.
Don't worry, I'll help you with the questions.
Yeah. So obviously, monogenic lupus, to make life very easy, is a child who's having very, very lupus like. Sorry. Hello.
No, sir. I think someone got an.
When you start seeing, for want of time, when you start seeing lupus-like presentations at a very young age. So by definition, the description of SLE, you will start thinking in an adolescent female, etc. But if I start seeing a 2, 3, 4, 5-year-old who's presenting with lupus-like features or some unexplained CNS delays, vasculitic lesions, unexplained proteinuria, consanguineous marriage, seizures, you will start thinking that this is a child. Had she been 12 years, am I looking at a possible SLE-like situation? And sure enough, you will have an autoimmune, you will have an ANA positivity. And one of the reasons is that early complement deficiencies. The kid is, these are typically kids who are born with familial complement deficiencies, which, like we know, can predispose this kid to either an immunodeficiency story, or you can have autoinflammatory stories. So monogenic lupus, again, will be confirmed on genetic studies, recognition of pattern, ask for a similar history in the family. And then there are different types of monogenic lupus. So you may be looking at something like called an Aicardi-Goutier syndrome. Quite a few of them, which is beyond our syllabus for today. But young age, 4, 5, 6, 1, 2, 3, family history, consanguinity, lupus-like presentation, you may be looking at a possible monogenic lupus.
So very well covered, sir. So that's what I got. I hope, Dr. Mahesh, this has answered your question, that the younger age group, outliers kind of situation where either CNS is more or skin is more or infection is more, then you consider monogenic lupus. So there are a few more. So ANA initially comes negative and later positive. Is that possible? Vice versa also. And is there any cutoff for ANA and anti-CCP?
The second question is easy to answer. The vice versa is never possible. Once ANA is positive, I will generally not repeat an ANA to document a falling titer. The only exception may be a post-infectious falsely elevated ANA where, again, ANA, the commonest reason in someone you send, it comes 1 in 100 or 80s possibly post-infectious, which may become normal, but as a rule, in a proven ANA disease, I will never repeat it. The other question, can you have a negative ANA initially becoming positive? Again, it's a bit unlikely. It could be a lab error, it could be a technical error, but then it's possible that ANA was not tested by the right method. Again, it boils down to the weekly positive again. What's weekly positive? The magical cutoff that most of us believe in is 1 in 160. Having said that, the lupus current classification starts talking about entering the SLE algorithm at 1 in 100. So bottom line is, why am I sending the ANA number 1? The pre-sending test probability of that test coming positive is most important. If I just send a random ANA, dsDNA that we used to do during our DCH days, and it comes 1 in 80, remember 25% of normal females will have a positive ANA in low titers. When it comes to dsDNA, it's a different ball game together. The double-stranded DNA can be negative to begin with, can become positive with a flare, or a rising dsDNA can point to an impending flare, can come down with normalcy. So negative ANA becoming positive, change the lab. Positive ANA will never become negative because I will never send a repeat ANA most of the times. Double-stranded DNA can be positive, negative, less, more, depending on the activity of lupus. And there is no cutoff to my knowledge about CCP. But if it is very, very borderline, I would probably choose to again interpret in the context of the disease, like we discussed, in combination with the clinical presentation and the RA positivity.
So thank you, sir. Very well covered. So in short, positive, once diagnosed as lupus, you'd never repeat it because that's not a marker for disease activity. Negative depends on the disease, whether it's in evolution, when are you doing it, repeat, how did you do the first test? Accordingly, you decide whether you repeat it to see whether it's actually positive or not. So that's the thing. And I think the second question you've already covered about the weekly positive lupus, weekly positive. I think there are no more questions in the chat box. Dr. Ram sir, yeah. So I think we can end the session. It's already 10:30. Still, people are really still listening to us and listening to you because it's like questions which have been very well covered, and an excellent session that you have done, sir. Covering smaller nitty-gritty, which are OPD based, useful techniques for pediatrician, covering simple CVCs, looking for platelet count, TLCs, lymphocytic predominance, looking for ESR and CRP together, looking for an AG reversal, looking for muscle enzymes when you're seeing, and undressing and examining what you have very well explained in your whole presentation, of course, and answering the questions as well, and also fewer lab interpretations which were covered on this thing. So it's a wonderful session, and it's always fun to listen to you with the fun and the pun. Both.
Okay, bye. Thank you.
Okay.
Wait. Bhavesh wanted to say something.
Hello.
And then I will say. Bhavesh.
Yeah. No, I mean, I keep learning from him on a, you can say, a periodic basis personally. So no more question to him, but as expected, excellent presentation.
A special thanks and sorry to Vijay to keep you awake till 10:30. He usually sleeps by 8:30.
I don't mind going on till 4:30 in the morning if you guys stay awake now. Return gift. 10:30 के बाद नींद नहीं आएगी मुझे.
कल 10 बजे फोन उठाया नहीं and now you are saying that you will not sleep.
नहीं, अभी खोल दिया ना आँख. अभी तो साइंस के तरफ से है. Even Shika will not sleep. We will keep teaching and teaching till you fall asleep.
अभी राम गोपाल सर आपको एक ललाबाई रिकॉर्ड करके भेजेंगे, एक लोरी.
And thanks, one more special thanks. You covered your